reaction, but in children we are also seeing some patients having a reduced growth velocity if the dose is high, to have fallen in the survival curve since the teenagers. So the advantage of the oral deferriprone by taking by mouth is well understood, but of course it also has its own problem. Like
by using the Buflu, like what we did, or busulfan cyclophosphamide, reduce the dose, like the southern part of China, Dr. Shun Fun he used, and add the fludarabine levodopa. Or Italy group, they want to get away from the cyclophosphamide by using the triosulfan, fludarabine, and levodopa. And mixed chimerism, I haven't shown the data. This is very important. And now, only one paper, CD34, they didn't get any good result at all. I think, thank you very much.
But the myeloid megakaryocytic maturation were normal. There were no excessive blasts noted, diminished iron stores were seen, cytogenetics were normal. A diagnosis by the pathologist of myelodysplastic syndrome was made. They said old FAB system, it's refractory anemia, given an IPSS score of int1, and the patient received 3 units of packed red cells, and it was on iron supplements. Actually, I take that back. This was when she presented to her hematologist. So now, what would you suggest be done at this stage? So a 63-year-old, start the patient on EPO, start on lenalidomide, hypomethylating agent, move to transplant or other. Okay, so start the patient on DNA hypomethylating agent. I think that's the right answer. Again, there's no right answer, obviously, but that's what I think I would do. And I'd like to see when Marcos takes the stand what he would do in terms of the allogenic transplant option here. One of the quandaries is if this patient responds to a DNA hypomethylating agent, do you take him to transplant or do you let them remain on the hypomethylating agent, and do you take the patient to transplant when he's starting to fail? Those are, I think, unanswered questions, but I'd like to see how Marcos tackles those.
Give yourself a little space at the end to tie it all together and to have things not work as well. But they like to see that you have that sort of organization. Okay? Innovation. They want to know if this is a novel technology or if it's a novel application of an existing technology. You don't always have to invent the light bulb, but if you're using the light bulb, to illuminate something else, they want to know why it's new. Okay? In that case, it's got to be conceptually novel. I'm going to take some other technology that somebody else has developed, but I'm going to apply it to a new situation in a different way, and this is why it's conceptually novel. Use the word novel. Use the word unique. Use the word innovative. But they don't do the specific narrow focus that you do. Okay? And so if you assume that your reviewer knows what you know, and you don't give them enough background in your background section, and you don't make things simple enough for them, you're going to get a bad score. Okay? You need to think about when your reviewer is going to be reading their brain. Okay? Now,
Any group or the ASO group were only put as alternative treatment. Now recently the echinocandin were also tested as a low-pathogen therapy for invasive aspergillosis in a limited clinical trial. Now this is 2 preliminary studies published recently. In a limited number of patients, you can see that about 30 to 40% of the patients respond to the use of these echinocandin, usually the plasmofungin, on different targets. Especially the echinocandin work on the 1,3-beta-glucan, the fungal cell wall. For the ASO group, they work on the ergosteroid synthesis pathway. Theoretically, the use of these classes might result in an additive or even synergistic activity. but quite a lot of in vitro study in this area. But the clinical study, so we are still waiting for the double-blind randomized control trial in this difficult area.
Okay, thank you, Chairman, for introducing me. And I also like to say thank you to the committee and for inviting me to this wonderful city. Sorry about that, but in the European data, the EORTC shows that the early 1990s, the gram-negative bacteria is still dominant, but after the prophylaxis with the quinolone,